Okay. Well, hello, everyone. Thank you for joining our May webinar in our lung cancer series here. Um, and, today actually we have a very interesting discussion, and really kind of we're privileged to have, such an elite panel to discuss molecular diagnostic strategies in lung cancer. So Dr. Joel Neal is here from Stanford, and really represents a lot of both clinical trials and also a lot of diagnostics actually that really coming out of Stanford, working collaboratively in the ctDNA space. And Dr. Geoff Oxnard, also at Boston Medical Center, and thank you, Geoff, for joining. You've kind of pioneered a lot of the work that actually I'll be presenting, so it'd be great to get your thoughts on some of this discussion. So without further ado, we'll get started. And again, this is really kind of setting the stage as what we know in lung cancer truly kind of has been defined by diagnostics. And it's really been a poster child to understand how diverse patients can be from from the lens of somatic mutations. Again, different populations and in different settings, some of these percentages can be different, but in the TCGA Nature project for non-small cell lung cancer and lung adenocarcinoma specifically, KRAS mutations about 25%, EGFR 28%, and again, that spans diverse EGFR isoforms. EGFR sensitizing mutations about 19%, exon 20 insertions about 2%. Really kind of thinking through the strategy here that it's not enough just to say a patient has an EGFR mutation. The type of EGFR mutation and the type of variant may be important for therapy selection, particularly as we know for exon 20 insertions. And again, huge list: ALK fusions, ROS fusions, RET fusions, BRAF V600E, MET exon 14 skip alterations, MET amp, HER2 mutations, and other mutations such as BRAF non-V600E also evolving in this space.
And this is just what we knew in 2014, right? This is like 9 years ago. And I think we'd barely scratched the surface in realizing how important all of these big gene rearrangements were. NTRK doesn't even appear to be on here, right? And MET exon 14 skips, like MET splice, they did find it in TCGA back then, but we didn't really appreciate the clinical significance for quite a while. So I think when we think about lung cancer now, we have 10 actionable driver mutations that we think about each individually with targeted therapies in the stage 4 setting for those.
And this also predates immunotherapy entirely, right? So it doesn't have that lens of what are those markers that might suggest immunotherapy sensitivity or immunotherapy resistance, right? And when I see a TMB30 case, I think that's its own weird species sometimes too, right? That lens doesn't fit in 2014, but it's been part of our thinking today.
TMB30 does great on immunotherapy, though. I can attest to that. Plus or minus any other clinical trial agent that they get.
No, really important point. And I think it also, for practicing oncologists in the community, really revisiting the concept that some patients may have had molecular profiling done many years ago. And as Joel has mentioned, the fact actually that some actionable genes may not have been listed on the reports at that time. And so now if a patient is seen post that first line therapy, really revisiting that genomic report to make sure that those genes have been assayed and qualified, I think is a super important point. This is particularly relevant for KRAS G12C. Joel has mentioned that on this slide, there's no NTRK, there is RET fusions, but I may ask this question, for both, Joel and Geoff actually on this now is, so Bert Vogelstein, when he first, there was a paper that he published really kind of as an editorial saying that most of the genes that are targetable have already been discovered or kind of presented. And, you know, do you feel like there's still a lot out there in terms of targetable somatic mutations or drug development or ways of the future that you see the field moving? Or do you just see more drug development with existing genes that we currently know about, and we're expanding the portfolio in those regards?
I'm happy to take a stab. What I'm hearing about more is almost vulnerabilities, Hatim, right? In the way that TMB might be a signature describing a vulnerability, right? I'm not sure BRCA mutations are a target in lung cancer, but I wonder if BRCA might be a vulnerability. And if you ask around, people will describe cases that seem PARP sensitive. And if we could codify that population to create, I'm hearing about other vulnerabilities like our HRDness that are trying to be exploited. Certainly, antibody drug conjugates are a whole new category of therapeutic targeted different kind of vulnerability. I wouldn't dispute that the single gene drivers, I'm not sure they're exhausted, but I think the yield from clean single gene drivers is attenuating, and we're actually thinking of newer ways of finding vulnerabilities that are probably going to have to be synergistic or orthogonal to the driver paradigm. Joel, what do you think about that?
Yeah, this is a very nice pie, and doesn't look at all like my family after they go after a pie on the kitchen counter. And, often there's 2 or 3 pies for a holiday, and we have to figure out like which one do you want and what's the most important one. And, I think the actual pie of lung cancer is going to be super messy. And we're going to think about proteomics. We're going to think about amplifications. We're going to think about mutations. We're going to think about rearrangements. And I always think about rearrangements, and maybe you said this, or maybe Peter Hammerman way back when, but like gene rearrangements are super strong. Like BCR-ABL, is a core driver mutation, and you need nothing else. Whereas mutations are a little bit weaker, amplifications even weaker, and these protein expressions are very heterogeneous. So I think about these pies are really, really messy, and we can subdivide them, but I think we're smearing them too.
At the same time, we're hearing about p53 inhibitors, right? Like, whoa, and I don't know if that's going to play out, but gosh, if you could inhibit p53, so I don't think the pie is exhausted. I just think the biology is going to be different as we find our next successes.
I think the unknown is probably bigger than 12% in lung cancer right now.
Yeah, totally,
for most, right. And, these are not mutually exclusive. I think we're looking at things like KRAS, and then we're subdividing that into little micro slices that people think have no calories.
Really important points. And thank you for providing that context about associations. It's not enough actually maybe in the future to say a patient is just EGFR mutated, perhaps EGFR and P53 or EGFR CDKN2A, with loss. So I think the field is becoming more messy in that regard. So the topic of this discussion also is now with novel technologies, we have additional tools, and plasma has really unfolded an opportunity for the future, particularly under circumstances where patients may not be good candidates for tissue biopsies, may have tissue inadequate, or there may not be a safe biopsy to obtain. So along those lines, plasma really has unfolded some opportunities. The field of cell-free DNA is not necessarily a new one, but in the world of cancer, I think what has, kind of moved the field forward is technologies that can identify somatic mutations and other genomic alterations in smaller fragments than what can be conventionally done with next-generation sequencing. And this is shown here on the slide where DNA is wrapped around histones. There is intranucleosomal DNA cleavage, which leads to a laddering pattern where there can be concentrations of genomic fragments of particular sizes. And the cell-free DNA that appears to be more cancer-derived is in this range of about 180 base pairs. And so this is, just some details about what is ctDNA, meaning circulating tumor DNA, which is distinct from cell-free DNA, which is the total amount of genomic fragments that may exist in plasma. So along those lines, now coming into this, one of the technologies that is depicted here is called targeted error correction sequencing. And basically these fragments in plasma, some technologies have utilized barcoding on the fragments and then redundant sequencing to isolate out jackpot mutations, which are reflected upon that redundant sequencing process as the genomic fragments are expanded. And that's in contrast to artifacts that can happen as part of the sequencing process, where they can be at different points in the in the fragment. And then there's a sequence reconciliation, alignment to the reference genome, the calling and identification of sequence alterations. There's different strategies. One is called hybrid capture, which really captures the fragments and then does genomic sequencing. There's another called amplicon-based sequencing, which really relies on the amplification of the fragments and there's particular issues that can happen as it pertains to creating some of those artifacts with each of those types of processes.
One of the reasons this is so great for ctDNA is that it's a very clean, fresh specimen with little artifact. And so you can find stuff way down at 0.1%, tiny low-level signals that you wouldn't be able to do in tumor specimens because they are historical, FFPE handled, there's much more noise. And so, as you would never call a tiny low-level signal in a FFPE sample because of the handling leading to artifact. You've nicely called out with a fresh specimen, you can sift through the artifact and find that signal. And so it's allowed us to dive deeper into specimens and get more yield out of these things.
And just to back up to the 30,000 foot level, like it always astounded me during my PhD that I could make a primer that was 20 base pairs long and find any unique gene in the entire human genome or any genome with that, right? So, if you do 4 to the 20th power, it's a ridiculously huge number. And you can find all of these things incredibly uniquely. So with very, very short sequences. So I think the important concept is the fragments of DNA are much bigger than the unique possibilities of base pairs around, right? So whatever the technology is, we can find things and we can say, that's not only human, that's not only, from this human, but that's also abnormal because it's from this human's cancer. Yeah. I'm always amazed by that. Sorry.
Really, it's an amazing opportunity here where that layer of granularity to get down into these types of error rates. And basically, one way to think about this is we're trying to find fragments, and this is 10 to the to the minus 5. So one fragment out of 10,000 fragments. Really kind of looking at that granularity. And with those types of barcoding approaches, one can get down into those layers of detection. So now how are these being used? And also, how are we using tissue? And so we're going to tackle a few different topics, really kind of also do some forward projections on, how are diagnostics really enabling treatment opportunities for patients? So, Geoff, this is one of your papers, actually going back all the way to 2016, now 7 years ago. It's remarkable to kind of think about how time flies in different ways. But I remember this paper actually when it came out because it really set the stage for thinking about concordance for T790M in the context of, really looking at how osimertinib was being brought forward and understood how we can identify the T790M mutations. And so, this paper, looked at plasma positive T790M samples, as well as looking at tumor tissue samples. And I think one important point here is that in tumor T790M positive, one could see in blue the plasma T790M positive. And then if we look down over here, plasma T790M positive, where they're tissue T790M positive. And if we look at those patients that were tumor negative, there are some patients actually that can still be plasma positive. And some people who were plasma negative, really there are opportunities where there can still be tissue positivity. To really set the stage that if you have a plasma negative result, still important to make sure that you're testing the tissue to make sure that you're not missing a positive tissue.
And I do think we saw
mhm,
less
mhm,
perfect concordance here because of the resistance, right? Resistance, T7IM, is so heterogeneity that you'll see it in tumor but not in blood, you'll see it in blood but not in tumor, but either one was actionable. Either one was associated with therapeutic benefit. I feel like at initial genotyping, it's a little bit cleaner, but the phenomenon you just described, which is a negative liquid biopsy, is always a dilemma. You might miss it in the blood if the shed is low, and that's where tissue can be a backup plan. I see this really as being positive tissue, positive blood, either one, you can trust, you can treat. And this was the beginning of that story.
Yeah, I agree. I've often used the phrase, you can always believe a positive, at least with a reputable genomics lab, hopefully, right?
Yeah.
Not necessarily true a decade ago in the lung cancer community.
Yeah. No, I think it was super interesting. And I also think actually, like for me, particularly when I saw these figures, one thing that resonated with me is, specifically in this figure on the bottom right is that, if you do have a plasma negative test, you can't not do the tissue. And I remember you actually had like a schematic in this paper or like a flow diagram actually where you looked at that.
And that's what led to the label of liquid biopsies, saying all the labels say, FDA approval after a negative, check with tissue, right? The expectation for the FDA is that we're going to trust the positives, but the negatives come with caveats. And that schematic, honestly, Hatim, is what built that label language that has now been in every liquid biopsy approval. Always be cautious with the negatives and always be sure to confirm that with tissue, or you might be missing something.
Yeah, I mean, also to reflect, like, EGFR mutations were first described 20 years ago, right? And the technology to find them has gotten a lot better. I think T790M was in 2005 originally. So, and T790M was always a little tricky to find just because of the sequencing pairs. So, believing the positives, though, hopefully we can always do that.
And, I think it's like so interesting actually that, now 7 years later or 8 years later or so, Geoff, you led this project actually trying to see how to evaluate the plasma negatives in a more real way, and I thought that was so interesting. So definitely, really, an important way to build that story and kind of build appropriate understanding, which stresses the point that if you have a plasma negative result, you really have to kind of have some additional ways to make sure that that patient is truly negative. One of those is tissue, and one of those is also, this concept, which, we worked on together, tumor fraction, and here actually shows that in patients with ctDNA, there are patients actually that may not have enough detectable circulating fragments in plasma, that can be as large as, it looks like over here, 70%. It looks 75%. And, this is, there's a tumor fraction coined as greater than or equal to 10%. And with that, one can see that at patients who have these higher levels, there's higher rates of detectability for positive results. And we'll go through that data. And so here actually shows that based on tumor fraction, one can find a whole variety of different alterations, base substitutions, insertions, deletions, fusions. TMB can also be better represented in patients who have higher tumor fractions, as well as gene deletions. Geoff, maybe I'll just take a pause here, and maybe for the audience, if you could describe tumor fraction, in a way, that you see it.
I like to think about the shed, the DNA shed of that patient in front of you, right? And that when you see a patient who has night sweats and liver mets, like there is probably a ton of ctDNA floating around in that patient's blood. I mean, like 10, 20, 30%. There's so much floating DNA in their blood that their blood is as rich as a tumor biopsy specimen. And if only you could see that DNA, like you would know that is a rich specimen, and you can learn everything from that plasma specimen, you could from a tumor biopsy, potentially, if it's designed right, okay? But there are other patients who have modest symptomatology, modest tumor burden, where the level of DNA floating around in that plasma is actually quite scant or even negligible. And the problem is you can't just hold the tube up and tell that you actually need some assessment of that level of shed, ideally from whatever assay you're using that will tell you, this was a great specimen. Oh, this was full of DNA. Trust a positive, trust a negative, high shed specimen. Or another interpretation is, look, we did our best here. We didn't find anything, but we're cautious of this negative because there was only a wispy amount of DNA. This negative needs to be checked with tissue. And so it's that idea of trying to measure for you, the physician, how adequate that blood specimen was to provide an informative, and especially an informative negative liquid biopsy. Joel, does that make sense to you?
I don't, yeah, I mean, it makes absolute sense, but do current reports from companies provide that information? I haven't really noticed that on the report, although certainly for tissue testing, they have a lot of caveats and they say these genes weren't covered fully and all these things, but I haven't seen that as much on the liquid biopsy tests.
Well, this is the biomarker. This is the paper here, right?
Right. And then the second question is, are there clinical features? You know, you describe them, but like, what do you think about for a lung cancer patient presenting? Like, what are the clinical features that you're like, this is probably a high shedder? You know, I think about tumor volume, more than a couple of centimeters of solid tumor, necrosis in the middle, brain mets don't shed very much. You know, like slow growing disease that's evolved slowly, like probably doesn't shed very much. Like, are there other things you think about, Geoff? Or
yeah, I don't disagree that when I meet a patient, I think of them, are they a good liquid biopsy candidate? Like, am I getting a sense, if they have wispy small lung nodules, like liquid biopsy is probably not gonna be informative, I gotta go find the tissue, right? I still think, Joel, there's a lot of people in the middle where I don't really have a good sense if they're shed, and I'm saying, well, I'll give it a shot. Like, let me just try. And that's where the potential of a tumor fraction biomarker helps me to know, oh, was this a reliable negative or not? And so that's the biomarker Hatim was reporting in this paper, maybe. And you can explain a little bit the evidence.
Yeah, no, and actually, you know, Joel, just to kind of, you know, because it is important kind of that, you know, oncologists know that there are commercial assays that do report tumor fraction. And in fact, actually Foundation Liquid reports this concept of tumor fraction. And so it is an important thing that, you know, at least is being evaluated on commercial reports. So again, and just to kind of, you know, stress what Geoff had mentioned, at least the way I think about tumor fraction is, you know, we need better confidence to understand how valuable a sample is. In the way that I understand it, you know, tumor fraction really kind of provides us a context to know that there is an estimation that there is ctDNA in the sample, and whether or not that results in the identification of an actionable driver. If there is no ctDNA or kind of limited ctDNA there, it can hinder the opportunity to find it.
I guess the tricky thing is for some of these like really simple mutation cancers, and when I say simple, I mean like, you know, EGFR, ALK-ROS1, RET, perhaps, you know, more the rearrangements. There aren't that many mutations overall. So how can you tell what the tumor fraction is in a less mutated overall cancer? You might be able to tell a definite negative in a smoking associated cancer because you're like, there's a lot different than the genome here. But in something like CML, you're only looking at one thing. And lung cancer's many-fold more mutations than that, but it's still tough to tell the tumor fraction.
So the tumor fraction is an estimation both of somatic mutations, but also copy number gains and losses, or kind of just structural changes. And so I think one of the things actually is that even if the cancer has a limited number of mutations, you know, compared to wild type DNA, cancer as a whole, even with limited number of genes, let's just say EGFR or such, still has a lot of, you know, structural changes.
This goes back to work from the Broad even years back across cancer types, that you can measure that aneuploidy you can estimate the tumor content using various measures, and that not only has adequacy implications, Hatim, but what the Broad found is prognostic implications. And so that shedding isn't just about how good is that blood specimen, but shedding tells you how aggressive is this cancer, and it can give you some sense of the risk of progression if we can just estimate it. I'm with you, it's a little bit easier with EGFR, Joel. You can measure the VAF. With breast cancer, it's a little bit harder. And so that's where this marker was designed in some of these genomics labs to be more pan-cancer.
And are companies reporting the certainty around the positive or the negative? You know, there are definitely companies that feel like they're over-reporting in terms of mutations, and companies that may be conservative, and we have no idea where they are on the balance, right? Like, you know, here's a mutation, and here's the certainty that it was from the cancer. Would be really, really interesting.
Yeah. Let me ask you this, Joel, actually, you know, just as someone who uses molecular diagnostics and such like this, do you feel it would be helpful to have more granularity on reports? Or do you feel like right now the finger in the pulse is that having less on the reports just really kind of what is, you know, the immediate need in front is what is needed? And also I'd love to hear from other oncologists on you know, about this question, because I think this is really an important question. You know, Joel, what do you think, actually, if you don't mind taking a stab first on that?
And anybody who wants to chime in is welcome to come on video. I see Dr. Georgis, maybe, who's been on video persistently the whole time, and nobody else. So if they come on, I'll see them. You know, I actually feel pretty strongly about this, that like the first page of the report, and only the first page of the report, should be like, here is an actionable mutation and do this with it. The whole companion diagnostic FDA thing, I think it mucked it all up, because, you know, there are certain tests that are approved for certain companion diagnostics, and then they'll put those at the top, and then other mutations will be like, hey, this might be important, but this is another mutation. So, you know, the 10 things that are actionable in in lung cancer, EGFR, and all the rest of them, those should be at the top, like, do this with this. And then page 2, the variant allele frequencies of everything, and maybe the certainty around whether that came from cancer would be useful to me. And then the next 30 pages can be clinical trials that I never look at.
No, that's
Geoff.
really important.
I mean, all I can say is that I think it's variable by user, and this is a big challenge, right? That sometimes I just want like positive, negative. I've heard community physicians say, I need the drugs listed, or I don't feel comfortable giving them. If I don't see the drug name on the report, I'm not sure I'm supposed to be giving it. I guess the flip side is you put too many drugs in the report, the patient expects me to give them all. And so I really struggle. What's the right balance here, Hatim? Like, are the clinical trials actually helpful? Just in case, is that leisure reading for the patient? Because the physician's probably not going to look at it, right? And what does any of this, like, how does this all look when it gets into Epic integration, and it's actually just like a text box that pops up, right? Because in the end, everything's going to get simplified with Epic, and it's just going to be like a very basic, you know, a few things. At the same time, you know, I'll get reports back that are way too thinned out, and they give me, you know, a variant, but it doesn't really tell me if it's actionable or not, or a VUS or not. And so I've gotten reports back that I think are oversimplified. So there's got to be a sweet spot, but I'm a little worried the sweet spot different for different doctors. And if anything, you just need to get a report you're comfortable with that works for your style. I don't know what the right answer is.
Hatim, I'm wondering what your reflection is on the CDX. You know, here we have a CDX indication for this versus here's something that might be important, but actually to me, it's really important. Like, it sticks out as like, you can't forget to do this. Geoff will excuse you from this conversation due to conflicts, but Hatim, what do you think about this? Because I actually feel pretty strongly that the CDX indications set up by the FDA, our government, have not really done a service to the medical oncologists who are looking at the reports.
Yeah, I agree with you. I think that unfortunately, you know, some very targetable genes don't have an official CDX. And yet, you know, if we excluded the patients from being able to get access to some of those types of medicines for those targets, I think that would be a challenge and not appropriate. So,
maybe not excluded, but just like we missed it because it was like, no actionable reporting CDX mutations is something you see sometimes. And then the bottom is like, here's a bunch of other stuff. And like keep one, STK11, and like EGFR exon 20 is like all together because that test didn't have a CDX indication for that assay.
Yeah, I would do want to. I'll admit I'm conflict. I'm employed by Foundation Medicine as my other job, which wasn't mentioned earlier. At the same time, there was, I don't disagree that reporting, is its own thing and needs to be clear. And the FDA doesn't necessarily draft the best reports. United Healthcare just decided to pay for NGS for a lot of cancer patients, and their approval was specifically aligned with CDX indications because to them, the utility annotation of a CDX is what led them to decide to cover, right? So we can debate the reporting value or if it's important at Stanford, but some payers have chosen that this is a measure of usefulness that influences them. And so, if it helps patients get access, I think that's an upside. But I don't disagree. It doesn't sway my decision making on a day-to-day basis necessarily.
And I would be totally fine if like all companies said asterisk, this is a CDX from a different company that we've done in a different way, right? Like there is a CDX for this, but Geoff and I can probably agree that nobody uses COBAS EGFR mutation PCR anymore, whether it's on the tissue or in the blood, but that was the first blood-based PCR test for EGFR mutant lung cancer.
Yeah, I think they use it in Europe, Joel. Okay, I think some parts of the world still use it. Okay,
it's the Wild West over in Europe.
So I think one thing that was really curious in this paper also is, citing and looking at the positive predictive, or the positive predictive value as well as the negative predictive value here. And here actually shows that for finding certain genomic alterations, when the tumor fraction is greater than or equal to 10%, the sensitivity for finding those alterations is a lot better than for an all-comer group actually that doesn't necessarily just look at those patients with higher tumor fractions. Also, in patients who have a negative result, if you have a negative result and a high tumor fraction greater than or equal to 10%, that correlates with a more reliable negative result. So the take home here is that, there are attempts to try to better granularize a true negative and also enhance sensitivity. And the tumor fraction is one of those strategies actually that can help discern and improve the negative predictive value. So there was, so there's some other analyses, and I think one important one here, which I really liked a lot actually, and this was also created by Foundation Medicine and Flatiron, really kind of looking at positive liquid biopsies prior to first-line therapy. And then in patients actually who had a negative liquid biopsy, who subsequently had a tissue analysis, 40% of patients who had an initial liquid biopsy could still have a targetable gene identified in tissue after a negative result. So really kind of, just shows some clear evidence that reflexing to tissue is really an important concept, and particularly important in those patients who have a negative liquid biopsy.
This result was surprising to me. Yeah, Joel, do you always follow through and make sure you wait for the tissue result after a negative liquid biopsy? I did not expect this much yield from tissue NGS after a negative liquid.
I mean, there are other companies that have suggested other information like Guardant, where you get more yield from the liquid biopsy than the tissue sometimes. Do I wait? It depends on what I'm waiting for, Geoff.
Yeah.
So like, am I waiting for an EGFR mutant lung cancer patient who's Asian woman, never smoker, who I'm like 60, 70% chance? Yeah, I'll wait and not give immunotherapy, which I think is the most important concept here. across indications. But for other, it's the pretest probability. So coming back to like what I asked you, Geoff, are they a shedder? Are they not a shedder? I have a good like in-brain pretest probability of like, do they have some never smoking associated actionable mutation that I should wait for? Or should I just push ahead with whatever and it probably won't show anything? But I do get tissue on everybody who's plasma negative.
Right.
It's really good.
I'm
Joel,
with
actually.
you. Sometimes you can't wait,
Yeah.
Joel, and sometimes you let the result play out, a month into therapy. But yeah, I've been surprised, and I found something I didn't think was going to be there, and I'm with you on that persistence to check tissue.
Chemo's always not the wrong answer. It's not the right answer, but it's not the wrong answer while you're waiting.
No,
except for the carbo shortage.
And thank you, Joel, for sharing your experience. Actually, that you really always kind of go back to get the tissue. I have to be honest, in my practice, actually, there have been patients actually who, with a plasma negative, have started therapy, and we're really now doing the diligence to go back and make sure that the tissue is analyzed. It's hard to sometimes get the tissue analyzed, and it really requires diligence. So a take-home perspective that I have really kind of taken away here is being extra diligent. You almost have to be extra cautious and extra, putting in the extra effort here to make sure that that's done.
I'll share two very brief anecdotes of Asian woman never smokers who I followed in clinic and picked up from other providers. And in one of them, it was, I saw her as a second opinion originally. It got started on various therapies, went all the way through all the therapies. I kept saying, repeat biopsy, do the liquid, repeat biopsy. Liquid was negative. Eventually got a biopsy and it was EGFR mutant. Like after all was said and done, like after like 4th line therapy, I'm like, great news. Like we found it finally. I smelled it all along. Another one was treated for, I kid you not, 18 years for EGFR mutant lung cancer that was like the slowest growing cancer ever and just creeping along, and got all these EGFR therapies, 2nd, 3rd line, 4th line therapies, finally repeat biopsy the tissue, and it was ROS, ROS1. It's like, it's ridiculous. These are totally the exceptions, right? Yeah. We've got to treat the major population, but we have misdiagnosed or, not found the mutation in a significant number of patients.
But I also had a patient recently, high shed, aggressive cancer, liquid biopsy, negative for EGFR ALK. I was like, all right, let's get going. And I was like, great clinical trial candidate. And the clinical trial was like, no. Can't go on with your negative liquid biopsy. You need to check EGFR ALK first. And I was like, this patient has a convincing negative. A high tumor fraction, convincing negative. I shouldn't have to check it. And I was like, well, never mind, skip the trial, just start standard of care. And so I'd like to be able to have some judiciousness in which patients do need the confirmatory tissue testing, in which patients I can skip that tissue testing. So that's the uncertainty I think docs are stuck with now, that hopefully we can try to open up with a little more clarity.
Well, if your tumor fraction percentage certainty was 99.9%, maybe we could write that in as eligibility for a ctDNA test, right?
Yep.
Really important points. All right. Well, thank you guys. I think we covered kind of a very important concept, which is concordance, really thinking through how do we evaluate the utility of a plasma result. With that, actually, kind of going into some other areas. So, Geoff, you had done this paper all the way back, many years ago now, almost 8 years ago.
Okay, wait. Mm-hmm. Anybody who's looking at the chat, because I put messages out there, tell me what AZD 9291 is in the chat. It's a time-sensitive competition. Go ahead, take it, Geoff.
It's a really good one. Actually, not many people may know AZD 9291.
Don't reveal. Oh, you can't. You're excluded.
You call me out. Someone's got to answer. Okay, I'm sorry.
Okay.
At least they're looking at the chat.
Tagrisso. Yeah.
This was the original name for osimertinib resistance, right?
And what was so curious about this is that at that time, liquid biopsy was being studied to look at first the initial genotyping, second is resistance monitoring for the T790M. And now in this paper, looking at serial analyses, that what was curious is that there were 3 types of patients that emerged from these types of analysis. Some that had a new second site mutation, C797, plus the T790M, plus the original mutation. Some patients actually where, they had the T790M persist, but perhaps a different bypass pathway or something that was causing the growth or, such. And then lastly, those patients who had suppressed T790M, not generate C797S, and still resisted perhaps a different bypass pathway there. So I thought that was actually very interesting. So this was all the way back now 8 years ago. And, Joel, from Stanford, your group working, collaboratively with Max Dean, also had, a pretty interesting paper around the same time, kind of looking at serial evaluations, looking for C797, T790M. I believe actually this was with ruxolitinib. And so, we also had a paper kind of where we were looking at dynamics. I think some interesting points here is that, initially early, we had some time points very early. So we actually had some time points even 12 hours after the administration of the EGFR inhibitor. And then some time points about 7 to 10 days after. One could see even that soon, at least the 7 to 10 days, you could see a suppression of the clone, that on top of the therapy, the clones were suppressed. Interestingly, for the 12-hour time points that we had, we could actually see a peak, a rise, a reflection of the cell death process, and then a suppression. And here shows that in patients who had response, you could see that suppression, and people who had no response, there was no suppression to zero, and in fact, kind of, escalation of the cancer.
I have a question around this. So, I've been trying for a while to promote this idea of like induced liquid biopsy, which is, we're taking a patient who has like a bunch of bone met progression, and we're radiating because they have pain in those bone mets, and then do a liquid biopsy, like when the ctDNA is at the peak, like what was the resistance? Because I'm not going to biopsy the bone, but what do you think the right time point is for that, Geoff and Hatim?
Really important points. So at least maybe I'll take a stab, Geoff,
Please.
First, and then and I think this is an important message to communicate here is that timing of getting serial analyses is still investigational and still being explored. And I think hopefully kind of with more analyses done serially, we can better understand the right time points to get that. I think there is a push in many investigations to try to find progression before CT scans. And so there's kind of almost like a hedging to get more samples or samples tested before the scan shows progression. And maybe that's one answer, but I think that, we're probably going to see that at the time of progression radiographically, or even beyond that time, is kind of when more likely we're able to qualitatively through ctDNA find resistance pathways identifiable in plasma. Geoff, what do you think about that? The right timing of serial analyses, how you see serial analyses moving forward?
Yeah, I've not had any successful experience trying to induce tumor shed, right? And if the patient goes and does jumping jacks, they're just as likely to have apoptosis of their non-tumor cells and lead to reduced ctDNA levels. So I'm not familiar with that, Joel. I really do think that it's about figuring out whether the patient has meaningful progression, and not uncommonly with EGFR resistance, the tumor will be growing slowly and the patient feels fine, and I'm not ready to change their therapy, so I'm not ready to send a liquid biopsy, because just as likely that liquid biopsy is negative. I try to defer my resistance testing until that moment when we are really talking about the next thing. I'm not going to deny I have those patients where I see a new bone lesion and I'm like, oh, it's resistance. And so it's like new bone met, send that liquid biopsy off and it's negative. And then it doesn't change. And maybe it was never progression at all. I've had patients with pseudoprogression on immunotherapy where I'm devastated. I send off the liquid biopsy and it's totally bland and I give them steroids and it all goes away. And so for me, the motivation is really that progression event that seems uncertain. Hatim, is there a future state where we're going to be checking to confirm our drug's working? I start immunotherapy and I want to recheck a couple weeks in. I'm excited about that future state, but we're still going to figure out what tools need to be used to make that world of monitoring happen. And I've not fully adopted, except for those moments of sort of immunotherapy uncertainty, is where I'm really double checking my work.
I
So may I ask you
agree.
first?
I agree, Geoff, with what you said, which is, I anticipate when I really want to change, but I back it up like 3 months and I'm like, okay, first we send the liquid biopsy, then we'll think about an actual biopsy that's super slow to get all of these things, including RNA analysis to look for those random fusions, so it's like, I tell the patient, like, in the next 3 to 6 months, we're probably going to change therapy in EGFR. Hatim.
No, actually, I'm just curious for you both actually to kind of say, what do you think is necessary as a prerequisite to adopt monitoring in lung cancer? What do you like? What type of data or what do you feel? And maybe Joel, if you want to take this first, is to say, so firstly, are you doing any monitoring in plasma? And actually, what do you feel like would be really important to convince you or kind of to adopt that type of practice?
Yeah, that's a tough one. So I think, first of all, am I doing it at baseline? I think the baseline is really important to know, are they a shedder or are they not a shedder? And we don't have that information on the vast majority of patients right now. And if we do, it's from heterogeneous testing, probably with different companies, at least in our group. So then are we following over time? I'm generally not doing that, but there are certain exceptions when we get to the early stage part of our discussion, which hopefully will be in the next 10 minutes. There are certain situations where, I think it is actually compelling, and I'll tell you what it is, which is adjuvant osimertinib. So adjuvant OC got approved, and people can get it who are stage 1B all the way through 3, whatever, as long as there was surgery. So I'm not personally testing for MRD, for residual ctDNA after surgery or before starting the osimertinib. We're doing that for research. But right before stopping at 3 years, I think it's compelling to say, like, is there still tumor DNA floating around? And then if we decide to stop at that 3-year time point, maybe a few months after, is there still ctDNA floating around? And if, at least for that one use case, if we find a positive test before they stop or a positive test after they stop, I believe that, and I would not stop the osimertinib.
I think there are 2 other use cases I thought about. My R01 at Dana-Farber before I left was to look at immunotherapy as an alternative to chemo IO with close monitoring, right? Are we over-treating some patients with chemo IO? Could we give them immunotherapy and monitor closely and add the chemo if needed? And so I would love a world where I could spare them chemo through monitoring Hatim. And that's, studies like that are ongoing at Hopkins and elsewhere. So that feels like a place where we could empower docs to use immunotherapy only, look for that sharp signal of benefit that's sometimes opaque on scans, and then be able to say, great, I picked a winner, and not need the triplet therapy. Because I really feel like we're over-treating some patients. The other one I'm more and more intrigued about is the confusion around 4, 5, 6 cycles in. Who needs a lot of maintenance? Who needs less maintenance? It's amazingly variable. Who needs intensified maintenance? And that's actually a place where I think there's a lot of uncertainty. And I wonder if monitoring could help us back off on the patients where we could back off and even intensify and add something to patients who don't. But it's looking, I think about those patients where docs aren't quite sure what to do next. That's a moment where I hope a good liquid biopsy can help them. We just got to figure out the right evidence to help with that decision making.
Yeah, no, I think the best use cases for liquid biopsy and sero monitoring are when we have de-escalation, right? We could actually save patients from side effects of treatment and save on cost of care for patients too.
Right, a year into immunotherapy, are there patients who could stop, Joel? Right, I mean, I hear about that all the time.
So I think I think it's going to be an interesting battle between diagnostics companies are saying do less and pharma companies, which are always like do more forever.
Well, good guys. I think this is, really important discussion. We'll have to see actually. And Joel, I may ask you actually, this point is, there are some assays that are looking at serial evaluations. Natera has an assay. There, other assays as well. Do you have experience with that? Are you using those in practice at all?
So we're doing a clinical trial right now where we do MRD testing on patients who have had all of their regular treatment, definitive treatment, radiation, surgery, chemotherapy, whatever, no immunotherapy. And then we test for MRD and we'll give them adjuvant immunotherapy for a year if they're MRD positive, with a primary endpoint of making it go MRD negative 3 months later. So we're kind of saying, we're treating micrometastatic disease. Let's make this go away. So that should work in the same patients that immunotherapy works in regardless. I'm more intrigued by these serial monitoring. And I think last I checked, I think Natera and Foundation had sort of a collaboration where the Foundation looks for the mutations and does like a comprehensive assay. Natera's value is that they do PCR primers that are custom to the patient. So it's a really inexpensive assay as compared with comprehensive genomic profiling when we're looking for 1, 2, 3, maybe up to a few. Geoff can tell us like what the maximum is, but they're not looking for more than 10, right? And these certain PCR primers, you could just make those and you can make them for the patient and save them in a freezer and do that assay serially over time for a lot less money. So I don't think it's actually cost effective to do comprehensive genomic profiling in early stage patients to monitor for recurrence.
How about this, Joel? What if you described the EGFR patient? I've thought about that EGFR patient of mine who said, I don't want to go back on therapy. I think she got adjuvant or erlotinib. She was one of the last patients on your trial, Joel, okay? And then she came off, she recurred. And I was like, all right, you've recurred. It's time for osimertinib. And she's like, I know what EGFR inhibitors feel like. I don't want it. And I watched her for like 3 years until I was like, okay, it's time to treat these lung meds. And she's like, okay, fine. And she started them and I was like, how is it? And she's like, it's not better than not being on therapy. And I was like, oh, burn. And my point is, are there some adjuvant patients who would rather monitor instead of treat, Joel? Is there a world where that monitoring approach you described could allow you to kind of kick the therapy down the road? They're studying this in bladder cancer. They're talking about it in melanoma. Are there patients who would want monitoring instead of therapy in the adjuvant setting?
Yeah, I mean, we do this, right? We do this with lung mets we see on a CT scan. I've done that for a number of patients who had EGFR, who 3 years later actually started the TKI. Yeah, I did this for one of Posse's patients 3 years later who came to California. And I do agree that patients don't necessarily want the treatment. I'm not sure, though, that I would make a clinical decision from ctDNA as opposed to tumor bulk, right? Yeah. We feel like we're pretty good with periodic MRIs, CTs of the body, maybe the occasional PET scan for people who have stage 4 lung cancer. And there are patients I've followed for a few years who are extremely slow growing. But would ctDNA tell me like I should start the drug? I don't think so. I think it's tumor bulk.
I mean, in the adjuvant setting for early stage, could you monitor for that recurrence and catch it as early as possible?
We should do that. We could do that. I think this pharma, is like, let's treat more and let's do more. And we're treating a lot of patients who will never have recurrence, right?
So maybe this is a good segue. Let's just, we will, talk
with
about
no disrespect to the pharma who's sponsoring this program, who may be listening and watching the recording. Okay.
So with that, actually, so let's talk about early stage. In the early stage, actually, there is an FDA approval for testing for EGFR based on the approval for adjuvant osimertinib. And I think one of the questions is, is there enough testing happening, right? Joel, in your practice, actually, are all your early stage patients tested for EGFR?
Well, I mean, as Geoff pointed out, we've been running early stage EGFR clinical trials for a long time. So we've finally gotten all of our pathologists to run something on tissue. And they all have tissue because they get surgical resection by definition. So it's high quality. It doesn't matter when we get the EGFR back, but we do get it back.
Okay. And are you doing NGS on that tissue in specimen, or are you kind of just looking for EGFR?
Yeah, we tend to do it all. I tend to recommend do only NGS and don't worry about the rapid tests that come back a little bit faster, because we'll look at it as medical oncologists, like after all is said and done. For neoadjuvant, it's a little trickier though.
In our practice, it's been hard to get NGS for early stage patients because NGS is approved for metastatic patients or locally advanced patients. And so along those lines, we've struggled with how to get the right testing completed, recognizing that we do stress NGS, so much in the metastatic setting. This comes in.
Yeah, it's hard to know what's right, and I'm not sure the guidelines tell us exactly what to do here.
So it is an unmet need, this is important to highlight.
When we talk in groups of academic people, we say like EGFR and PD-L1 are super important to know for neoadjuvant and adjuvant. And the rest of it, it's a little less data driven, but we know it's going to be important.
I do think the checkmate neoadjuvant study was EGFR or excluded EGFR ALK patients, right?
EGFR and ALK, right?
Yeah, right. So I think it's moved to EGFR ALK now as a base case, but I don't disagree that the additional evidence is still accumulating.
But exclude EGFR and ALK is what we did a decade ago, right, Geoff?
I know. I hear you. I fully believe in the value. I mean, I've heard docs say, no, I'm not going to test the stage 3 patient until they recur in their stage 4. And I'm like, well, okay, you're playing a roulette there. Like, get these patients recur, and you're then waiting around to find testing. And so I definitely think there are patients who are missing out if they don't have these results in hand. It's a really uncomfortable place to put docs and patients in.
And NGS is so comprehensive, accurate, affordable. Like, I really think we need to move the needle to more early stage.
So Joel, I may ask you, just because there has been a heavy emphasis on liquid biopsy in this discussion, is do you use the liquid biopsy in early stage patients? Have you ever done that? What has your experience been there?
Certainly most of the commercially available CDX tests are not sensitive enough to detect MRD that we were talking about. And I don't usually send liquid biopsy for somebody who's going to surgery, because I know that they're going to get surgery and I'll have tissue. And if I give neoadjuvant and they have a path complete response, path CR, I'm like, great. I don't even need to know. It was great.
Yeah. So I think that's a good take home.
There's one study looking at this, the LCMC4 leader trial is a neoadjuvant targeted therapy trial. And so they're investigating, can liquid biopsy help those results get back quicker, Joel? What we don't know is the sensitivity. And so we expect in early stage, the shed's lower, the sensitivity is lower, the burden of negative results is higher. And so we still need evidence to know if it's useful enough to add to the decision-making.
Right. So again, you could, just like stage 4, you could exclude people from certain therapies,
right? But
you can't necessarily say like, I'm guaranteed that this therapy will work.
Yeah, no, and I think that's an important point. I mean, here shows some of the work we did with this assay known as TechSeq, where if you look at stage 1 lung versus stage 2 versus stage 3, really the sensitivity for finding ctDNA alterations increases based on the burden of disease. Here actually shows, looking across a variety of different cancers, if you look at stage 1, stage 2, stage 3, and stage 4, in general, stage 4 patients will have more detectable ctDNA, than even with comparable cfDNA. So really kind of mutation specific due to the cancer. So maybe in our last few minutes, actually, we're going to tackle this concept of biomarkers and immune therapy. PD-L1 incomplete biomarker. This is PD-L1 negative. This is this is positive. We can see, highly positive, but there is this gray zone of how we actually truly define different levels. It is being called by pathologists, and having a more quantitative assessment that can be used, in addition, may be helpful. So I think one of the trials that really framed some of the thinking here was this neoadjuvant study led by Patrick Ford, looking at monotherapy with nivolumab. I think what was curious about this is that in this study of about of 21 patients, by imaging, only 2 patients had PRs, 18 patients had stable disease. But when they actually looked at the samples from the resected specimens, a large number of people had major pathologic response. It's really kind of highlighting the concept that imaging may not always be the best way to assess patients. And so, there've been other analyses. I think this paper also looked at shared T cell clones between the tumor and blood. Also looked at, those T cell clones in the people that had major pathologic responses. There was an additional analysis to look at plasma pre-treatment and at the time of surgery, before surgery, to show that those patients who were molecular responders had more correlated major pathological responses as well. So with that, actually, I may just ask you both, as some parting comments over here, what is your take on TMB or other biomarkers in immune therapy? I think one element of that last paper that I presented is they looked at the initial upfront TMB versus the serial dynamics, and actually published that the serial dynamics seem to correlate better with outcomes than the upfront TMB. Geoff, actually, how are you thinking about TMB? What are you aware of where TMB is moving? Can you provide us some of your thoughts there?
Or BTMB?
Yeah, I'm first going to say BTMB is the blood-based version. Careful with that, right? I mean, that's a place where every BTMB is calculated differently, and some of them are massively inflated. And so I would be cautious on BTMB. To me, it's really, what is the dilemma? The dilemma for me is I feel like I'm giving too much chemoimmunotherapy sometimes, and I would rather find more patients for immunotherapy. And I do believe that there are patients who are PD-L1 10 or 20% who are fine for immunotherapy alone. And that's where I see TMB as a complementary biomarker, which can help me sway towards favoring IO over chemo IO. I'm not sure 10 is adequate for lung cancer. There's a paper saying it's more like 20 that we worked on. Mark Awad had a paper saying more like 19 worked. And so I look for higher cutoffs where I'm going to try to really persuade me as the immunotherapy candidate, but it's really just complementary to your clinical instincts. And for an aggressive patient, I'll give them chemo IO. And for a patient who I might want to spare the chemo, I'm looking for a biomarker that might help. And I don't think TMB is the whole story, as you point out, Hatim, and other genomic markers might also help with that decision making.
Joel, any other thoughts about TMB? Are you currently using TMB and looking for that in your practice?
Yeah, I think like Geoff mentioned at the very, very beginning, that my eyebrows raise when it's a tissue TMB above like 16. And I think that's a very unique subset of patients. So that is like driven. Immunotherapy alone can definitely work. And, let's focus on that. In the intermediate, I think it's a swamp right now, and we don't know what to do with it. For PD-L1 0, TMB high, maybe I'll give CTLA4 antibodies, and there's 2 that are FDA approved now, tremelimumab and ipilimumab. So I'll sway toward those, but I don't generally use those other than high TMB. The problem with TMB is it comes back kind of later too, right? So at least we do like rapid EGFR, ALK, and ROS, and then I have my clinical prediction and blood, and then blood TMB is a problem. So like if you get a really high TMB later, we've probably already given the treatment that we're going to give. So I don't know what to do with it, and we just I think we released a sit-see position paper after a year and a half of work with a lot of immunotherapy leaders and me that said, we don't know what to do with TMB.
I mean, one way that I found TMB helpful is that if I have a patient with a very high result, it helps me in my communication with the patient too, just about, as they ask me about chemo or immune therapy and such, it also does come into the discussion there.
Maybe that's a patient
So
where
with-
you could spare the pemetrexid maintenance and focus on the immunotherapy maintenance. Like there still are ways that you can right size their therapy, maybe. Yeah.
I mean, I think Hatim, to your last bullet point here, like dynamic therapy provides insight. If CTNA dynamic monitoring were as cheap as CEAs, we would all do it, right? You know,
Yeah.
I think the barrier is cost and uptake. And you know, in lung cancer, I never check CEAs because I don't want to know. So there may be that other side of the coin too. It's like if the CEA is up and your tumor's totally fine on scans, do I really want to know and do something, or are we going to pretend everything's okay for a while, even though that we know that it won't be? So, you know, is more knowledge good? I think that's the debate here.
Yeah, no, I think it's really critical, and also I think framing your point, Joel, as well is that if we know which time points are truly essential, you know, I think that also helps us estimate the cost in the long run for a patient. So with that, actually, you know, want to thank you both, you know, for your excellent, you know, thoughts and kind of just willingness to participate here and you know, share your insights. You both are truly leaders, you know, and really, you know, kind of feel honored that we're able to spend this time with you. So with that, actually, you know, want to turn it over to Dr. Laskari. Thank you so much,
Yeah.
Dr. Laskari. And,
No,
and
thank
any
you guys.
last,
I apologize for
viewpoints
coming in
on-
a little bit later, but I was very pleased to hear this amazing discussion, as I'm sure all of our attendees are. Thank you so much, Dr. Neal, Dr. Oxnard, for always bringing your A game to our webinars. We really appreciate it, and it really kind of makes the discussion more lively. And this is certainly one where I think in the next year, talking about this, we're going to have lots of changes at play. So, and I wanted to thank you, Dr. Hatim, for putting together the moderating the discussion, and to our sponsor, AstraZeneca. And thank you to our attendees, and we'll see you next month. Thank you, everyone.
Okay, thank you guys.
Thank you. Bye.
Bye, guys. Thanks.